This lecture is primarily related to the heart, but I want to make it emphasis on basically the physiology. That's what I broken heart. If my professor of anatomy was alive, he say, "Kyun dil ki baatein kar rahe ho bhai? Dil to toot chuka hai." Lekin right now, in my vocabulary, I'm using the physiology now. In the past, if anybody who has thought about the heart failure, because the broken heart, I'm using that term, the heart failure primarily was the fluid accumulation, and take the fluid out as you see in the picture. That was the classical picture from the library, where you put a big tube and take the fluid out, and that was considered in the past as the treatment to the heart failure, because it was not developed. And very unfortunate, some of you may not recall, the cardiac physiology, the first time the pulmonary circulation was developed, not by not Harvey, who everybody attributes the development of the pulmonary circulation to. Actually, it was Al-Khairi. Back in the 12th century, it was a Muslim who developed the whole concept of the pulmonary circulation. And that's why it stimulated me so much when I started my cardiology, that with no resources, if you could concentrate on the physiology, with my resources, why should not I? So every time I'm talking of the heart failure, the broken heart, I'm looking for the physiology. How to deal with the physiology has gone where at that time haywire, it has become pathology, and the patient is suffering. So let's talk about the heart failure now. The outline that I'm going to discuss in this lecture at this point would be define what heart failure is, look at the epidemiology, how at that time how frequent patients are, what is exactly, especially United States, that's what I have to tell you because I don't know the statistics in Pakistan. What exactly is the pathophysiology? What is the classification of the heart failure? And what are the current treatments available? And some new therapeutic, which I'm not going to dwell today because I like to leave this lecture, hopefully for the second year and the third year and the fourth year, along with the postgraduate can benefit. Okay? So let's just talk the definition first. Heart failure is a pathologic state in which an abnormality in cardiac function is responsible for, number one, the failure of the heart to pump blood, because that's the function of the heart, to pump blood at a rate commensurate with the metabolic needs of the body. And number two, the pulmonary congestion. Okay? So those are the two very important things. The heart has failed to pump blood, and because of that, metabolic need of the body is not met, because that's the function of the heart, pump the blood to supply the nutrient as well as the oxygen to the tissue, in the process remove the excretions back. And number two, because of this, the fluid accumulates in the lung. What is the incidence and prevalence of the heart failure? As I said originally, I'm talking about the United States. Approximately 5 million Americans have heart failure. 500,000 new cases are diagnosed yearly. And this, by the way, this is 2004. Now even higher, because the lifespan is, and more older people we are seeing it, and we are seeing more than that. The risk of heart failure increases progressively with age. Now, the lifespan, if you are 60 years old in the United States and you don't have any chronic disease like hypertension, diabetes, and so forth, you are supposed to live by 92. Women, 98. So now the age span is increasing, so the heart failure incidence is increasing. Heart failure is the most common diagnosis in hospitalized patients over 65 years. Risk of sudden cardiac death is 6 to 9 times than if the patient does not have a heart failure. Now, in this slide, you can see between ages 45 to 64 and 65, and this is the figures between 1971 to 1997. Look at in the red line. Look the incidence of the between how is it gone up from 1970 to 2000, people in over 65, while the incidence of heart failure has also increased between ages 45 to 64. But the incidence much higher, because as you're growing older, the chances of a heart failure lasting longer will be much higher. Hospitalized rate for acute myocardial infarction has also increased. Now, it tells you one very interesting thing, that some of the causes of the heart failure may be myocardial infarction, because the age is increasing, the heart failure is increasing, the myocardial infarction increasing. Also increasing between the ages of 45 to 64. So that, in other words, when we are dealing with a heart failure, it's not one common disease. It is a syndrome due to many diseases that we will see. Now let's define the function of the heart. With that sort introduction to why we are discussing the heart failure. The heart is a pump which performs the function of volume displacement by developing pressure differential based upon a tension generating shortening. What does that mean exactly in simple English? The blood is full, the ventricle is full of blood. Fluid always translates into pressure. So it's developing, contracting to develop more pressure to open the outlet valve so the blood can be ejected back into the aorta and the pulmonary artery. That's what it simply means. Now, this is the most important graph that you can see, and hopefully you will retain it forever. Not in second year, not in third, fourth year, but the postgraduate as well, because this alone would teach you everything literally. Let's start. This is one pressure tracing developed in the left ventricle. It could be the right ventricle. I'm going to concentrate on the left ventricle. At this point right here, at this point, the blood has come into the into the left ventricle. So much right now, the left ventricle is full, and more blood can be accommodated coming from the left atrium into the left ventricle across the mitral valve. So the mitral valve must close. And same thing happening in the tricuspid on the right side. So I'm going to call it inlet valves. The inlet valves close. The ventricle is full, but it doesn't have as much pressure in it to open the outlet valve to eject the blood. So now this phase is called isovolumetric contraction, because the ventricle is simply contracting to develop the pressure so that it can open the outlet valve. And that's exactly what happens. Outlet valve open, now the blood is being ejected. Now this is a very interesting phase. As you see in the red, which is the pressure in the aorta, in contrast to black, which is the pressure in the left ventricle, both are continuously rising. Very fascinating question. Why? When the ventricle is emptying itself, volume is getting less and less. Why on earth the pressure keeps on rising? Simply because it has to overcome the pressure in the aorta, which has got its own muscle. It has got own resistance to it. Therefore, the ventricle keep on generating more pressure to overcome the resistance into the aorta. And that will be the concept as we will discuss it in afterload. Now the pressure in the aorta is decreasing, ventricle is decreasing, therefore the outlet valve must close so that no blood will regurgitate back into the ventricles. Now the ventricle is relaxing, getting ready to receive blood from the atrium back into the next diastole. So right now, at this point, the inlet valves open, the blood rushes very quickly. This is called rapid diastole, and you have slow diastole. At this point, let's go back and see how we can use this physiology for auscultation. As the inlet valve closes, you have a sound. Mitral component and the tricuspid component. There are 2 or 3 more sounds which are more turbulence, and they are not as important in clinical practice. So we have between the opening of the outlet valve and the closing valve is a true ejection phase, and this is the true systole. This is the ejection phase. When the outlet valve closes, you have the 2 sounds called the aortic and the pulmonic closure sound. The aortic pulmonic closure occurs first. Aortic closure sounds occur first before the pulmonic closure, because the pressure in the aorta is higher than the left ventricle, in contrast to the pressure in the pulmonary artery, which the right ventricle has to face. So this is your basic, very crucial, true, worth remembering is the physiology, as well as the basis of auscultation, and the whole thing that we'll discuss in terms of the heart failure as well. So we have learned 3 things from this diagram. That we have an isovolumetric contraction. The first heart sound, it tells us that this is the beginning of the systole or the end of the diastole. Now we know what the ejection phase looks like, and we know what the isovolumetric relaxation is, and what the outlet valve they close, what the sounds are produced.